Yeah, thank you so much, Sri. All right, if you can get the board up, Elena, do you want to take the first crack at the aliquots?
Sounds great. Yes.
Wonderful. If you could get the board up, we can get started. Team, anybody can share their screen? Wonderful. Thank you. All right, Sri. Go ahead.
Okay, so we have a mid-20s female who presented to the emergency department due to rectal bleeding that started about 2 months ago. They described an episode as painless with melena and hematochezia, filling the entire bowl every time they had a bowel movement for the last 2 months. They state that they had been
Oh, I'm
hospitalized.
so sorry, Tree. Sorry to interrupt. Team, we're not seeing the screen, the board.
Vinny, I think we're in the wrong Chrome window
Yeah,
because we can see the email but not the board.
Yeah.
Perfect. Now we can see it.
Wonderful. Thanks, Yusuf. Hi, friends. All right, Tree, do you want to restart?
Yeah, I'll start. All right, so
thank you.
So they went to the emergency department for rectal bleeding that started about 2 months ago. They've had black tartar stools, also blood filling the bowl that's bright red for the past 2 months. They state that they've been hospitalized before for similar symptoms. So far in the emergency department, they've received 2 units of blood and they've been placed on a somatostatin drip, IV protonics, and then we put in a consult for GI. And then they're currently admitted for medical management. For a review of symptoms, really they've just been experiencing some fatigue for the past 2 months. They've denied blood in any kind of vomit. They don't have kind of bright red spots like petechiae. They don't have mucosal bleeds, fevers, or chills.
All right, Chi, what a start to this case. So yeah, this is really interesting. I think we have had some cases where we discuss bleeding, rectal bleeding, and I think whenever I approach bleeding anywhere, I think before I even think about what etiologies this could be, I really think about management for this patient. So when somebody is bleeding heavily, we want to make sure that we have good vitals. So we want to make sure that we're not going into the direction of shock. So we want to look at if there's any tachycardia, if there's any hypotension, if we have to balance that with IV fluids or even erythrocyte concentrates. So that is definitely the thing that I would be looking at first, and just the general appearance of this patient, if they look toxic or not. So when I hear GI bleeding, then I generally think of just bleeding per rectum. So this is more, there's more causes for women because they can bleed from their GY tract, but I definitely think of hematuria as well in this patient. But usually what we see is that patients are pretty good at localizing if there's not some form of dementia, where the bleeding is coming from. And obviously in this patient, they have been hospitalized before. So yeah, I tend to believe that this is true bleeding per rectum. So when I think of bleeding per rectum, I think of actually the entire GI tract. Tree was telling us that it seemed like fresh blood. So it seems like that it seems to me that it is somewhat in the periphery of the GI tract, so like lower GI tract, what I tend to think about. But if the patient tends to have associated diarrhea, so like very fast bowel movements, then it could also be from the upper GI tract. So yeah, I think generally I would be interested in if there's some like inflammatory nature to this. bleeding, and it's interesting to me that this seems to be only happening in the GI tract and not anywhere else. So Tree was asking the patient for any petechiae, mucosal bleedings, etc., and there seem to be none. So I think there could be some anatomic abnormalities that could be causing this. But I'm definitely curious if there's like any other associated symptoms that we can dive further into. Yeah, I think that's how far I can take it from here.
That was fantastic. I literally, Elena, have nothing to add. That was so thoughtful and thorough. And I really love how you started thinking about management first. Like, and I 100% agree with you is that if somebody's coming in with like active bleeding that already has required 2 units of blood, you really, really want to make sure you first tackle hemodynamics. And off the bat, just make sure you have good access, like large bore IVs if you need to push fluids, type and screen, thinking about like, your no misdiagnosis and kind of like a lower GI bleed. Hematochezia is like brisk upper GI bleeds. So making sure to evaluate for that. If they remain hemodynamically stable, then you're like, okay, maybe most likely this comes from the lower GI tract and not upper GI tract. But couple of things that in all comers you want to think about, things that are really fast: cirrhosis with variceal bleed. Again, 24, quite young, probably not likely. The other ones are thinking about I think of arterial bleed, like ulcers that have eroded through, that causes oftentimes like a rapid bleed. That again, something we should think about. So for her, just not having heard about, a lot of the hemodynamics other than she got blood, I just quickly will ask some of the upper GI questions, NSAIDs use, alcohol, those things to get a sense. And then, as you mentioned, just hone into the lower GI bleed category of what this could be. One thing that I'm struck, 24 is quite young to be presenting with GI bleed. So the two things I'm thinking about, as you mentioned, Elena, is that, oh, is it some anatomic abnormalities? Oh, and also thinking about take a step back and see hey, does she have any hematologic issues that makes her more prone to bleeding? And if she has a benign lesion that is just more prone because of any hematologic. So that's something that, to keep an eye out for. And in terms of a lower GI bleed, common things being common, like diverticular bleed can be episodic. However, quite young for that. It can happen, but young. AVMs, hemorrhoids are another common etiology. The one thing, as you mentioned, Elena, that, in 24, thinking about your colitis, your IBDs with this kind of episodic bleeding is another thought, another thing to think about that tend to be bimodal. And everything else is tends to be a little bit less common. So those are the thoughts I have as we go through this patient. So definitely in the meds, want to ask about meds that make you more prone to bleeding or can cause ulcers. And it would be helpful to know if she has any family history of autoimmune disease, any familial GI syndromes. So yeah, I'm excited to hear more. Try.
Yeah. Okay. So starting off with the past medical history, they've had a history of cirrhosis. They've had a prior hospital admission for a gastric ulcer that caused a GI bleed. They have bipolar disease, depression, anxiety, and asthma. As far as, hold on, I'll wait up just so I don't speed along too fast. Okay. As far as medications, it should be noted that they're currently incarcerated and they don't really have a good medical history. Right now, the only medications they're on are the ones that were pretty much given at the hospital. So they have Plasmolite, continuous PRN, Protonix, 40 milligrams, and then hydroxyzine, 25 milligrams PO for both.
All right, should I start, or do you want to start, Sharmin?
Go for it, Elena. Go for it.
All right. So the first thing that caught my attention was that the person seems to be in a very special social situation. The patient is incarcerated, and generally, what I think when patients are incarcerated is that they have less of a good access to the health system in general. So I would think that maybe there's some like under treatment or less screening for diseases, although this patient is still very young, of course. And then, yeah, the cirrhosis is definitely something that that is quite striking as well in this patient. And cirrhosis is usually a disease that I associate with older patients. So I think the most common causes for cirrhosis is alcohol use disorder. And then we have our hepatitis. And yeah, I think in this young patient, I think even if there wasn't any mention about alcohol use, but I think it would be unlikely for it to cause this cirrhosis at such a young age. So I'm more prone to thinking of something like something like a hepatitis. Yeah, and the complications that can come up with cirrhosis is something like varices, and they're unfortunately very prone to bleeding because of the portal hypertension. And something that is very important in a patient with cirrhosis that bleeds per rectum is that you don't only want to give that you want to give an antibiotic, which is namely ceftriaxone. You might also consider, if the hemodynamics are not that good, to give terlipressin to get that vasoconstriction in your splanchnic arteries. This really depends on whether the patient is hemodynamically stable or not. Yeah, unfortunately, the varices can bleed very heavily, and it's very hard to control that usually. With endoscopy, you can like clip those varices, but they tend to progress. And without a transplant, usually this is a very bad prognostic value. Yeah, I feel like there's a lot going on actually with this patient with the underlying psychiatric disorder, and I'm just reading right now the medications that the patient is on. I have to be honest that I don't know PRN or protonic, so maybe Sharmin, you can tell me what that is. Yeah, at this point I'm mostly thinking that the variceal bleeds are responsible for the recurrent bleeding in this patient. I definitely would be curious to know how the prior hospitalizations have been and what kind of management they did. Yeah, and in general how the cirrhosis of this patient is managed at this point. Yeah, and maybe if this is even like a potential transplant candidate.
Brilliant. Absolutely brilliant, Elena. I couldn't agree more. I think the cirrhosis diagnosis is a game changer and also a head scratcher a little bit. And I love that, right off the bat, when you saw cirrhosis, you're like already thinking about varices, because we think about often esophageal varices. People can have like rectal varices as well that can be very prone to bleeding. So I totally agree that like getting a better understanding of her underlying cirrhosis will help make some diagnostic progress, because does she have compensated or decompensated cirrhosis? Does she have any other evidence of like portal hypertension? Is she thrombocytopenic? Like there's many different reasons why a patient with cirrhosis could be more prone to bleeding, and I think it would be and I think like knowing how her cirrhosis is affecting her would be really informative. And the other curiosity I have, as you mentioned, why does a 24-year-old have cirrhosis? Toxins can affect everyone oftentimes. And sometimes with medicine, I feel like, we don't quite understand why certain people with toxins develop cirrhosis early. Some people don't. What caused you to have alcoholic hepatitis over, just like fibrosis? So It always like humbles me when younger people with like toxin use, like alcohol use, develop cirrhosis, although probably is not going to be on top of my differential. And so similar to NASH, as you mentioned, like NASH, alcohol, it tends to be the most common etiologies in the United States. And again, in 24-year-olds, probably thinking about more genetic etiologies, thinking about autoimmune, again, like that's another thread that can link both the GI bleeding and the liver involvement, would be like autoimmune phenomena. And that one other thing that caught my eyes, as you mentioned, is that she's had a history of a gastric ulcer that led to bleeding. I'm not sure if she presented more with melena rather than hematochezia at a time. But then the question becomes, as you mentioned, someone who's like incarcerated, usually like the medications are dispensed. However, as in society at large or anything, people get creative about getting their hands on medications. So, just probing her kindly about like, oh, has she been exposed? Has she been like taking a lot of ibuprofen or things like that that would make her prone to another GI bleed, I think is where would I start. Protonix is just a generic name for pantoprazole, so PPI. Um, so, and yeah, that's all. Yeah. And I think, as you mentioned, like the exposure history is going to be key. I think hepatitis are a great thought in her as well. Again, like don't really associate it with a young person developing a cirrhosis. And as we're talking about, I'm like, I should work on my framework for a young patient presenting with cirrhosis. uh, Elena, any other thoughts before we pass on to Tree?
No, me too. I should definitely work on that schema as well. I think something that came to mind was alpha-1 antitrypsin. I think this can happen in young patients. And something else that came to mind as well, besides the varices that can build up, the liver is also responsible for producing those procoagulants and anticoagulants. So you never really know on which side you are in a patient with cirrhosis. Sometimes they tend to develop thrombosis, especially portal vein thrombosis, but you can also have a lot of bleeding complications from the patient not producing those coagulants.
Yeah. 100%, absolutely. And like exam will be really helpful, right? Because if you start seeing like if she has like ascites on exam or extremity edema, then you're more likely to be like, oh, she's in the decompensated categories. And then again, thinking about like the coagulopathy, everything else, then it becomes wide open that this could be any complications of cirrhosis, as you mentioned. And at the same time, it could be absolutely unrelated. That's why we love medicine, right? All right, Tree.
Yeah. All right. I apologize. I didn't finish the family history, the social history. Let me do that now. As far as family history goes, there's a history of alcohol abuse in the mother's brother. There's no prior surgical history. And then as far as social history goes, they have a history of alcohol abuse from 2014. They drank 14 16-ounce cans per day. And they only stopped when they had gotten incarcerated. There's no smoking history, no illicit recreational drug use, and then there's no pets, no sick contacts, no travel history. As far as allergies go, they have a shellfish allergy, they get urticaria, and then if they take NSAIDs, they tend to have rashes. And then I can move on to the vitals as well. All right, and so for vitals, the blood pressure was 135/94, heart rate of 114, temperature of 98.4 degrees Fahrenheit, respiratory rate 17, BMI of 26.63, and then their O2 saturation was 97%. On physical exam, their general appearance, they were A1O times 3. They weren't in any acute distress, but they were very pale. As far as hint goes, they were perla, extraocular muscles intact, no scleral icterus, nor conjunctival pallor. There's no nasal discharge, no pharyngeal erythema or exudates. And then for neck, just non-tender, no lymphadenopathy. Respiratory and cardiovascular, clear to auscultation, bilaterally, normal respiratory effort. Heart was regular rate and rhythm, no murmurs, no gallops. As far as GI abdomen goes, they had abdominal tenderness to palpation in the left upper quadrant. They were soft, non-distended, bowel sounds were present. As far as neuro goes, all their cranial nerves were intact, no facial drooping. They could move everything, sensation and motor grossly intact. And then as far as skin goes, they were not jaundiced. They didn't have any appearance of any rash. And then we also had examined just kind of the anal area, just in case, because they're incarcerated, if they had any kind of past trauma or anything like that during their incarceration, but there wasn't any signs of any kind of physical trauma.
All right. Yeah, that's a really interesting case. Tree, I think it's so great that you're bringing this here. So I can see that the vitals seem to be kind of stable. The patient is afebrile. I'm not using the Fahrenheit in German, but I think they're afebrile. What is concerning to me is the heart rate. So sinus tachycardia, some say this is the most concerning supraventricular tachycardia that you can have. Because what we think with sinus tachycardia is the patient, and young patients can compensate for a long time, compensating for for actually an intravascular volume problem. And how long can they do that? So for now, the BP is normal. And something else that comes to mind when somebody has a sinus tachycardia is if there's like catecholamine excess. Usually we see that on the BP as well, which we don't hear. So I'm more concerned that this could be the patient compensating for potential intravascular volume loss. So we have, when I move forward in the exam, the patient seems to be pale, and we have had other signs that there could be some anemia going on in this patient. First of all, of course, the bleeding itself. The fatigue and the review of symptoms was something that caught my eye before. So I'm definitely looking forward to getting that hemoglobin in that patient. Usually in acute bleeding, we don't see that on the hemoglobin, because we only see that when the body responds in a way that they get the volume back into the body, and then the hemoglobin goes down. Otherwise, what's concerning is the tenderness to palpation. Did you notice any ascites in this patient, or was it not present?
It wasn't present.
No ascites. Okay. Generally, if the patient had ascites, sometimes this can actually mask abdominal pain because of the fluid that's between, so to say. But in this patient, we have abdominal tenderness to the left upper quadrant. I think with abdominal pain, we generally want to think of extra abdominal causes, which doesn't seem to be a prominent feature here in this patient. And then or the way I go is to be afraid of morbid causes. That's why we have the now I'm forgetting the mnemonic, but it's definitely about obstruction and perforation. So that is something that I'm very worried about in patients with abdominal pain in general. And the left upper quadrant is an area where you have the GI tract. You could have some, and Sharmin mentioned this before, you could have some diverticular there that could potentially be inflamed. That is something that can hurt. Usually we expect that more in the left lower quadrant. We have the spleen there, and we already have signs of portal hypertension with the varices. So I'm wondering if there could be some splenomegaly, and something that is worrisome in this patient if they have maybe an acute increase in their pressure is something that the So usually when the spleen enlarges in size very quickly, it's due to thrombosis. And something that we are worried about is autoinfarction that can happen, which could potentially be the cause of this left upper quadrant pain, but it can also be something very non-specific in this patient. But I would definitely do a point of care ultrasound in this patient to see if there's any signs of portal vein thrombosis. Yeah, I think that's how far I can take it right now.
That was amazing, Elena. You're just like so thoughtful, so thorough. And I love how you always like think about the pathophysiology as well as you're explaining things. That was like so fantastic, like incredible. I can't do any better than that. And yeah, this case is like getting even more and more interesting. I think, going back to that social history and health related behavior, like significant alcohol use, which, definitely makes one of the etiologies in terms of like alcohol-induced cirrhosis a bit more likely. However, don't want to anchor. The other thing that really caught my eyes on exam, I was really thinking about, this diagnosis of cirrhosis and then looking for any signs that clue me into the diagnosis of cirrhosis on exam. And oftentimes, like, portal hypertension is one of the complications, but what is most specific in terms of your exam is like signs of hyperestrogenemia, like gynecomastia, or pulmonary erythema, your telangiectasias. And we don't see that on this exam. The one caveat I was like thinking about, I'm like, oh, if you're like so anemic that you're pale, are you just not going to see those findings as well? I don't know, but maybe. So, but again, like it's interesting to me that we don't really see any signs of cirrhosis. Yeah, it doesn't mean she doesn't have it. I think like labs, like looking for thrombocytopenia, the coagulopathy would be very informative. However, just being open to diagnosis of, as of now, I just have a question over that cirrhosis. And then I think we can revisit that with like further labs. And I loved, you know me, I love my known misdiagnosis. So the fact that you were thinking abdominal pain and you're thinking the obstruction, the hypodemonic, like the vascular pathology, the itises, the perforation and obstruction was just gold. And with the left lower quadrant, again, I think this is someone that has bought themselves some imaging. I think ultrasound is a great place to start. I would be curious to see what their creatinine is, or someone that potentially a tube of truth would be informative as well. So I'm curious to see the labs and see if that can help us make some more diagnostic progress. Oh, and Tree, I really thank you so much for doing a rectal exam and thinking about trauma and thinking about like sexual assault. Something that is like really hard to think about, and the fact that you guys were thinking about it and actually looked out for it, that it shows just what wonderful. This patient is lucky to have such thoughtful physicians to really think about patients wholesomely. So thank you for doing that, and thank you for sharing that with us. I'm glad she didn't have any evidence of trauma.
Mm-hmm. Yeah. All right. And so then starting off the labs with the CBC, white blood cell count of 2.06, hemoglobin of 6.0, hematocrit 20.7, MCV 66.8, red cell distribution width 13.4, and a platelet count of 82. We did a reticulocyte count, so 2.5%. And then the immature reticulocyte fraction was 18.1. Haptoglobin, we ordered that as well, 8. And LDH was 278. For the CMP, sodium was 142. Potassium was 3.5. Chloride was 110. The bicarb was 24. BUN 10. Creatinine 0.74, glucose of 108, calcium of 8.5, magnesium of 2.0, phosphate 3.9, and albumin of 3.0, alk phos 122, ALT 19, AST 26. Bilirubin total 3.7, and then the total protein was 8.3. We had done vitamin B studies as well. B12 was 431, and B9 was 37.3. And then let's see, we had done some imaging as well, so I'll throw that in there. We kind of skipped straight to a CT, abdomen and pelvis with contrast, and it showed splenomegaly with trace intraperitoneal ascites, no cirrhotic in morphology, and cholelithiasis without evidence for acute cholecystitis, and then a small hiatal hernia. We also did a colonoscopy, an endoscopy, and then the capsule endoscopy as well. And all of them showed no evidence of any signs of internal bleeding or lesions in the GI tract. A peripheral blood smear was done, and it showed significant anisocytosis and poikilocytosis with significant hypochromia. Normal platelet morphology without clumps. And so the impression was red cell morphology suggestive of anemia that is most likely chronic iron deficiency related. No myelodysplasia, leukoerythroblastosis, or microangiopathy. There is a direct antigen test, the DAT. I feel like it might give it away, but if you guys would like it, I can also give it too.
Maybe this is so much wonderful information. Actually, maybe we can talk through this together. What a great case. Thank you so much for presenting this. Elena, what are you thinking with all of this data?
Yeah, I also want to say this is a fantastic presentation. I can't believe that you're doing this for the first time. So when I saw the white blood cell count before the other labs, I was thinking, okay, this is leukopenia. And I think whenever I see a leukopenia, I really want to get an HIV test. But then the other labs came up and we got the hemoglobin, which is low. We got the platelets, which is low. So we're in the frame of pancytopenia. So I think the patient has a couple of reasons why the hemoglobin is low, namely the active bleeding that they seem to have. The MCV sort of gives us another clue that this could indeed be iron deficiency anemia from, for example, chronic bleeding, but we could also anemia of chronic disease, which is the second most common cause of anemia, could cause this. And then we saw the platelets, which are low. And in the context of splenomegaly, this is something that is sort of expected because if the spleen gets big, it sort of eats up all the thrombocytes. And something else that happens in cirrhosis is that it doesn't produce the TPO anymore. So it doesn't induce the thrombopoiesis. So there's like two reasons why patients with cirrhosis can have a low platelet count. And then there's another one, because if you drink alcohol as a cause of the cirrhosis, you might just suppress your bone marrow, which could definitely be at play in this patient responsible for the pancytopenia. And generally, when we see pancytopenia, if we see cytopenias, we want to know, is this like a peripheral destruction or is this something that is happening in the bone marrow? And the more cell lines that are on the hook, the more this is likely to be a primary bone marrow process. Something that is a really great lab value that we can get in these instances is a reticulocyte count, because it sort of gives us an idea of how much the bone marrow is able to compensate for the cytopenias. And I'm not sure with the normal range, but I'm assuming this is low. So we kind of confirmed that, the bone marrow can't keep up with the low cytopenia. So I'm wondering, Is there like Tree and their team did the studies for nutritional deficiencies like B12, folate can do that as well. But I think they're normal. I'm not 100% sure. So if this is not a nutritional defect, then we are wondering, is the bone marrow empty? For example, in the context of aplastic anemia, or something infiltrating the bone marrow, like in like a leukemia, like a granulomatous disease. We had a great case last week from Kirtan with TB, like a granulomatous infiltration of the bone marrow. And then whenever you have cytopenias, even if you only have thrombocytopenia, actually, you want to make sure that you're not dealing with hemolysis. We've had a case before where we had a very normal hemoglobin, just thrombocytopenia, and it turned out to be hemolysis. And clues that we can get is cell destruction, which we can sometimes see with the LDH, which we do here. We can see that with the AST, which is normal in this case. And then we want to get the haptoglobin because it gets low if the erythrocytes are being destructed, and then it binds to it, so it gets low as the free haptoglobin. Yeah, and I think we are dealing with hemolysis in this case. And there's a variety of causes of hemolysis. I think it's very curious to look at hemolysis in the context of cirrhosis. I don't have a perfect framework for this. But generally, when you see hemolysis on the labs, you want to get a smear to look for schistocytes. Which we didn't see here. We only saw signs of like anisocytosis or poikilocytosis, which is usually a clue to iron deficiency anemia. Yeah, but generally the way, I don't have a perfect framework for hemolysis, but the way I think about it is something from the outside destructing the cell, like antibodies, or something wrong with the erythrocyte itself, with the membrane, or with the inside. And something that we usually want to get in this context as well is a Coombs test. So we want to see, is this immune-related destruction or not? Yeah. And I think this is how far I can take it with the lab. I definitely need your help, Sharmin, to like get this a little bit further. And then we got the imaging of this patient. We confirmed the splenomegaly, like we had a little bit of ascites, which is definitely expected in this patient. And I think it's very interesting that despite the rectal bleeding, that we don't really see any signs of active bleeding right now in the colonoscopy. I think I'm just very, very excited to learn from this case and read more. And I'm so excited to see what you think, Sharmin.
Yeah, complicated case and brilliant. You don't need my help, girl. You got this. Like, you definitely don't need my help, even a little bit. That was like such a beautiful way of like walking through, and again, like connecting it to like haptoglobin and how does it work. Well, some of the like the best memory tools to use is like understand why things happen, and like your ability to be able to tie that back into why things happen the way they are. Like with the haptoglobin was like so cool to listen to. Interesting case. Can I just confirm one thing? Sounds like on CT abdomen and pelvis, there was no evidence of cirrhosis, so the liver was a nodule or anything like that.
Yeah, so the impression was not cirrhotic in morphology.
Got it. Fascinating, right? So we have someone, a 24-year-old, who came in with what we think it was like a lower GI bleed, who carries this diagnosis of cirrhosis, that with labs that shows pancytopenia and evidence of like portal hypertension with imaging, right? Like he had the splenomegaly, she has a bit of ascites, but classically, the liver is not cirrhotic in, at least like in the CT abdomen pelvis. So what to do from there? Let's first start with her presentation, which was a lower GI bleed, and the fact that the colonoscopy, endoscopy, and capsule were very negative. So right now, as you mentioned, there's no active sign of bleeding, but this is a person who has like chronic iron deficiency and anemia. whatever is happening that could be like episodic in nature. But I think for now we can just say like, okay, at least from that perspective, are not worried about active GI bleed, and we'll come to that if she becomes symptomatic again. And then let's put our focus into the pancytopenia and also this like portal hypertension. So most common etiology for portal hypertension is cirrhosis. Now let's think about like non-cirrhotic causes of portal hypertension. So we think about like, the intrahepatic causes, the hepatic causes as well. And so thinking about like, it was an IV contrast that was done. So they didn't appreciate any clots that would cause it. So thinking about like any infiltrative diseases in the liver that can cause that, like from like schistosomiasis, like alcoholic hepatitis can do it. And then thinking about like kind of like post-hepatic with like compression as well, pre-hepatic, sorry, with like compression as well. And with the pancytopenia and the portal hypertension, I always like to think about infiltrative diseases that can infiltrate both as a possibility. The other thing about like pancytopenia that I think about is like most oftentimes when you're pancytopenic, you're dealing with the bone marrow issues. There are a couple of rare causes of periphery. One is like splenomegaly itself, right, can cause pancytopenia. And the other one is actually, thinking about lupus and like autoimmune diseases that can do it. The pancytopenia, multiple system involvement, I think like lupus can do what lupus wants to do. So I think, again, like thinking of the young patient, that's something that is going to be on my mind, whether we're dealing with that. Yeah, I think the hemolysis is a great thought, and I think a tree also clued us into it. But I think like to take a step back in terms of like the hemolysis itself, one thing about the haptoglobin being low, haptoglobin like tends to be the most specific lab findings for hemolysis. A few caveats to that is like if patient have cirrhosis, haptoglobin is produced by the liver, so people can have falsely low. And sometimes like distinguishing between like cirrhosis and hemolysis is so hard to do. And then the other thing is like if patients got a lot of blood, a lot of the time, like if you're thinking about doing like further hemolysis workup, any blood that she's gotten does take away that can mess up with that. So something to be aware of. But I love your idea of like getting the dad getting a more hemolysis. And the way I think about hemolysis is like, what can happen inside the cell, what can happen on the membrane of the cell, and then what can happen in the environment of the cells. And, as you mentioned, like schistose is a good thing to think about like with MAHAs. And we don't see that. So a little less likely for this to be DIC. We don't have like our coags, but a TTP HUS, I think is a little less likely. I think a membrane of the cell, thinking about PNH, your autoimmune hemolytic anemias are good thoughts. And I think especially if we're going down a route of autoimmune hemolysis, we can talk a little bit more about that. About like again, the big medicine with that is like why. So how can we tie in the portal hypertension with like possible hemolysis would be the other question to ask. And the last thing I was like, oh, that MCV is really low. So thinking about like any other like hemoglobinopathies that can cause that as well. Like oftentimes like I think about thalassemias that have that low, but again like it would be like more carrier given that she's like 24 and otherwise not symptomatic. So and she has like really terrible like severe iron deficiency anemia, so maybe that alone can do it. But yeah, I think going down the hemolysis route makes sense. I would think about like lupus a little bit here as well. And if we've done our workup with evaluated the bone marrow radiologist hemolysis, can we just chalk this up to the splenomegaly? Sure. But again, I think that remains a diagnosis of exclusion. Any other thoughts on Elena before we hand the mic back to Sri?
Yeah, I'm so glad that you're highlighting that cirrhosis is a hard diagnosis to make, and I'm definitely curious how it was done in this patient. But yeah, as you highlighted, there is not really any clues that this is indeed cirrhosis. So like you said, we should think of non-cirrhotic causes of portal hypertension because we have a lot of clues towards that that portal hypertension. I think worldwide it's just with the myosis, so I don't know where this patient is coming from in the world, but yeah, this is definitely something to think about.
This is an incredible case tree, and you're doing such a phenomenal job presenting, by the way. All right, tell us more.
All right, thank you. So I'll give off the last lab that was done. I actually didn't know this until this patient, but as part of pre-transfusion protocols, direct antiglobulin tests are performed. And so the DAT was positive for IgG, and the antibody ID was warm autoantibody, which also gives off the diagnosis, which was warm autoimmune hemolytic anemia. And then yes,
All
like
right.
just like Holly said, SLE.
Again, can you repeat the last part? What about SLE?
All right, so I'm just reading off in the chat, and
Okay,
Dr.
so
Sokolova is cracking me up.
so it sounds like, she was diagnosed with like warm autoimmune hemolytic anemia. Let's talk about that, Elena. What are your thoughts about the warm autoimmune hemolytic anemia?
I will admit that there's not a good framework that comes to my mind. I know that there's warm, and then I know that there's cold, and yeah, I think it's due to different immune globulins. Um, I think the cold one is IgM usually. It looks like a pentamer, that's why it's called like a snowflake. And then there's the warm autoimmune hemolytic anemia. I think autoimmune hemolytic anemias in general can cause thrombus formation. I don't know if, yeah, it was with contrast, so we're not worried about this before, but maybe the thrombus has resolved and is coming back and going. So I'm still like looking for why the patient has this these signs of non-cirrhotic portal hypertension, but I don't have a good differential diagnosis for warm autoimmune hemolytic anemias. I need your help.
Again, you're doing a fantastic job. Yeah, so very fascinating. So, one of the things I love about medicine that you can never stop asking why. So it's like, okay, cool. This person has warm autoimmune hemolytic anemia. Love hemolysis. Love nerding about hemolysis. Why? Why does this person has warm autoimmune hemolytic anemia? And oftentimes, when things of idiopathic, I feel like about like 50% or something can be just idiopathic, right? But the other associated causes, and I feel like that was the chat, we got so excited about lupus, and I got so excited, is because one of the diagnoses that is associated with warm autoimmune hemolytic anemia is lupus. And so I think definitely I would work this patient up so that send your double-stranded, your ANA. And the other one's like your lymphoproliferative disorders. Again, like she's quite young for that, but thinking about like cancers that are associated with it. There's sort of like immunodeficiencies that are associated, I think, with autoimmune hemolytic anemia, and like infections like Babesia can do it. So I think the next question for me is like why this patient has, and the part that I'm not so sure about, like, except like, the lupus part of it, like how do I tie it to the pancytopenia, and how do I tie it to the portal hypertension that we are seeing? Is this like completely unrelated, or we, as you mentioned, like we still have like a little bit more work to do to see that, like the pancytopenia, the splenomegaly, chronic hemolysis, like all that kind of like makes sense. But the portal hypertension one is a bit head scratching to me right now. Any other thoughts, Elena?
No, I think yeah, maybe if we really can go back to our pre, intra, and post-hepatic schema for non-cirrhotic portal hypertension, I think something else that came to mind also with the pancytopenia is lymphoma in this patient, which could also maybe cause a warm autoimmune hemolytic anemia. So yeah. I don't know. I'm not 100% sure what the next step would be if the patient would potentially need a liver biopsy or if we want to look at the bone marrow. Yeah, but I'm just so excited to learn from you, Tree.
Yeah, I think that, and oftentimes, with worm, we often give steroids once we are sure they're not any infection. And I think it would be informative, like how she does with it. And oftentimes, people can get retux from it. If it doesn't really go away, people sometimes do splenectomy. So like spleen might be, at fault here. But yeah, this is like such a cool case. Tree. What did you guys end up doing and what did you learn?
So we were going to end up doing more antibody studies on the patient, but this person is incarcerated. We had stabilized them. There wasn't more need for them to stay in the hospital at that point. So we had notified the jail doctor that they need additional workup and possible treatment. But I believe the jail doctor said that it's unlikely to happen. So after we had gotten this patient done and everything, we couldn't really follow up more, but I just thought it was really interesting because I at the time, at least, I'm just a medical student, but I wasn't really thinking of autoimmune hemolytic anemia. And so I thought it was really cool that before any kind of pre-transfusion protocol, you always do that. You run the test and it can actually make the diagnosis for you.
Elena, any thoughts before I jump in?
No, I would be curious to know, like, Tree, how did you glue it all together, you and your team, with the presentation and with the portal hypertension? What was your thoughts?
We were really confused because we thought it was GI related. So we went through our entire differential with GI bleeds and just kind of like I think many other people were confused on after imaging for colonoscopy, endoscopy, and the virtual capsule. We couldn't see anything. There was no lesions. There was nothing. We were even considering repeating the pill endoscopy just to see if we had missed something else, but there was still nothing. So it's still kind of unknown how this person had, heavy hematochezia, where they were reporting that it was filling the bowl like halfway through with blood. And we were just kind of shocked because if this is something that's been happening before, then, how could this, go unrecognized or even undiagnosed? So then we really just kind of like explored the other autoimmune possibilities, and then that was it. Yeah.
Yeah, no, thank you so much for sharing that. I think there's so many ways to dive deeper with some reading. So I'm like so excited to do that. I'm definitely curious. What do you think, Charmaine?
Yeah, no, thank you so much for bringing this case. And yeah, I don't know either. And because like blood transfusions can cause like warm autoimmune hemolytic anemias as well. So is it the chicken or the egg? So yeah, and I think with time we'll hopefully we would know more. I'm a little sad, to be honest. And thank you, Tree, for so much for like advocating for this patient. But I think it is a sad commentary of our healthcare system that, the circumstances of this patient is affecting the care they deserve. And this is like something that should be followed closely because again, this is a 24-year-old, who has like portal hypertension, who has autoimmune hemolytic anemia. And it just like makes me really sad that most likely the next time the patient is going to see care is when they get sick again. And I worry about this like recurrent episodic thing that she's having that would most likely, cause more issues, cause worsening splenomegaly. Because I think we still, despite Tree and his team's best efforts, they were also constrained with what they can do in the hospital. So, but I hope she comes across physicians who are able to, make further progress on that because I don't know. But yeah, but thank you so much for sharing this. This is like such a fascinating case. And yeah, if you ever like hear anything more about this case, Tree, you have to let us know. I'm thinking about this young patient. Elena,
Yeah.
any other thoughts before we pass the mic to Winnie?
No, thank you so much, Sharmin, for discussing this case with me and giving me guidance through the case. I really learned a lot, and thank you, Tree, for bringing this case. It was a fantastic case and such a great presentation. Yeah, I also want to thank Julia and Vinny for doing the teaching points and scribing. Yeah, all of this would not be possible if you wouldn't do that. So thank you so much to everyone.
Elena, you're so brilliant. I wish I was as good as you are. Like this is, you're just absolutely brilliant. It was an absolute joy to discuss with you. Treat, you're a rock star. Thanks for presenting this case. Julia, thank you for describing. And Winnie, we're ready for you.
So amazing discussion. Thank you for the case, Dang. And our patient presented first with a GI bleed, and the first thing that we need to think when it comes with this presentation is about hemodynamic stability, and we need to proceed with ACLS if the patient needs intubation, if he or she is in vulnerable situation of hemodynamic instability. We need to have a large IV access in clinical and surgical management. So the vitals should be checked right away. Possibility of shock associated with tachycardia or hypotension. And we need to proceed with erythrocyte concentration in some labs. We need to see if the patient needs some fluids and proceed with an endoscopy as soon as we can get. And if there's any variceal bleeding in the endoscopy, it should be clamped. And if the patient is in hemodynamic instability, you can also proceed with a Sengstaken Blackmore tube. And also vasopressors are a good possibility to be considered. And if the patient has fever and you are thinking about some infection, you can proceed with ceftriaxone, also start at octreotide and somatostatin. So after that, after the initial stabilization, you think about some possibilities and associations, and we'll think there is any kind of hematuria that is present and the patient like is bleeding for rectum or is presented with hematochezia. This is a first time bleeding episode or a recurrent episode. The variceal bleeding, we need to think about a hypertension, portal hypertension, and we'll think about if this is a pre, intra, or post-hepatic cause, and if this is a cirrhotic or non-cirrhotic causes of portal hypertension, if this is a venous or arterial blood, this could represent a ulcer. If the bleeding is rapid or slow, if the patient is have some exposure such as alcohol or medication exposure such as NSAIDs, ibuprofen, or even viral infections such as hepatitis B, C, CMV, EBV, HIV, or even autoimmune hepatitis. Other exposures that we can consider should come to mind, and even malignancy in a young patient. So we have a wide range of differential diagnoses that we're discussing in the chat, and also we need to think in the entire portion of the GI tract, if this is a lower or upper GI bleeding, if this is associated with diarrhea, or what is the etiology. If this is a inflammatory, it is associated with the taking because of bleeding or any anatomic abnormalities. And also, as our patient has a young age, the roll up of the age here is a big role. So we need to investigate the hematologic issues, thrombophilias, any kind of familial history, hemophilic syndromes or genetic diseases, or any kind of hemorrhoids, inflammatory bowel disease, such as Crohn and ulcers, and finally the sexual history. Then we'll proceed with, we'll see that the patient had a social vulnerability, and this could be associated with under treatment or even under screening, and this can contribute to the development of the disease and the natural history of the disease. that's it. And the patient also had a sinus tachycardia, and we need to differentiate about the pattern of the tachycardia, if it's a ventricular or supraventricular, if this is a chronic and compensatory mechanism to the low volume, and if the blood pressure is high or low. This could represent a catecholamine excess, or this is a chronic sign of anemia. Then we will see and proceed with some labs, and we'll investigate if this is a hemolysis or cirrhosis, and the haptoglobin could help us to differentiate between both of them, because each represents the destruction of erythrocytes or deficient production of liver. So you can see the role of the haptoglobin here. Besides, the high ferritin could represent an inflammatory pattern, and also a iron overload that the patient is suffering. So if we have a chronic hemorrhage and iron deficiency anemia would be suggested. And also you investigate some deficiency of clotting factors if this is a disseminated intravascular coagulation, and a blood smear could help us. The patient was revealed to have anisocytosis and polypocytosis, but you also investigate the chromia if the patient has a hypo or a hyperchromia. Also, the direct the Coombs test. It is a very important test to be proceed, and you can differentiate between a warm and cold hemolytic, alpha hemolytic anemia, and about leukemias, and also lymphoma should be investigated. Finally, the abdominal pain could be investigated with the VIPO, pneumonic and vascular inflammatory parasitic causes could be investigated, also perforation and also obstruction. So our patient was revealed to have pancytopenia, and the first thing that needs to come to mind is this is a peripheral destruction or a bone marrow suppression. Alcohol toxicity could be related, granulomatous infections, tuberculosis, and even aplastic anemia could be associated. And the final diagnosis for us was a warm alpha-hemolytic anemia that, due to the entire clinical spectrum and also the age of the patient, could be related to lupus associations and lymphoproliferative disorders, even infections such as Babesia, and finally malignancy. So that's all. Thank you.
Wow, Winnie, that was amazing. Thank you so much for putting those amazing teaching points together and capturing the discussion so incredibly well. Y'all are absolutely amazing. Thanks all. What an absolute pleasure. Elena, you're a boss. Thank you so much, Julian, Vinny, and thank you, True. You have to come back. This was so fun.
Yeah. Thanks for having me, y'all.
See y'all later. Bye. And thanks to everybody in the chat. Your all comments are fire. Bye.